Welcome to another episode of BeeWellWithMS podcast. Today we delve deep into multifaceted topic of multiple sclerosis and pain, a symptom experienced by countless individuals with MS. Pain can vary from mere discomfort to intense suffering, deeply affecting the lives of both MS patients and their close ones. Joining us in this enlightening conversation is not just an expert in the field, but someone very close to my heart, Dr. Douglas Natusch. Over 7 years ago, when I became a consultant neurologist, Dr. Natusch was more than a mentor to me. His unwavering support, guidance, and open-hearted approach have been instrumental in my career. And these qualities shine through in all he does. Currently, Dr. Natusch serves as a pain consultant specializing in pain management, and he sees numerous amounts of people with MS. He is affiliated with the Torbay and South Devon NHS Foundation Trust as a consultant in Anaesthetics and Pain Medicine, and holds an Honorary Consultant position at the Rowcroft Hospice in Torquay. He's also Associate Dean, Torbay and South Devon, Peninsula Medical School. In our discussion today, Douglas will illuminate the intricate connection between MS and pain, highlight the prevalence types of pain that MS patients undergo, and outline the diverse strategies to address it. Together, we will touch upon the pivotal role of healthcare professionals in pain relief, strategies for patients to champion their own care, and how lifestyle adaptation can potentially alleviate MS-associated pain. So join us on this enlightening journey and let's get insights from Dr. Natusch. So welcome to this episode, Douglas.
Well, thank you, Agni, and thank you for the very lovely introduction. And thank you, everybody. So as Agni said, we're here to talk about MS and pain, which is a very interesting and multi-layered subject. And over the last 24 years, I've been a consultant in pain medicine. I've seen a lot of patients with multiple sclerosis in the clinic, and try to work very closely with the neurologists where we can, and the multiple sclerosis team to support people. But Agni, I know you've got a few things you wanted to ask, so why don't you start the discussion and we'll sort of let it roll on.
Thank you for this little intro of yourself, and I would like to know a little bit about the MS as a disease. It has got various different aspects in people's lives, and we are very much aware of the pain that people suffer with, and there is a relationship between the MS and the pain. Can you explain a little bit, what is this relationship between the MS and the pain?
Well, it's always lovely to be asked that by a neurology and multiple sclerosis expert, but essentially MS, multiple sclerosis, one of the primary problems is people experience a condition called demyelination, which is where the nerves lose their sort of almost like the sheath around them that helps them with their conductivity. And I won't go into the reasons why that happens. It's largely thought to be an autoimmune disease, but different nerves in different parts of the central nervous system, and where the central nervous system and that becomes part of the peripheral nervous system become affected in MS. And so, for example, if it affects predominantly sensory pathways in the nervous system, people often get very funny and strange feelings. We use the word dysesthesia as just a Greek word for meaning funny feelings, basically. But people can get pins and needles, and sometimes itching, pressure, sometimes even hot and cold feelings. All sorts of really strange feelings can happen as these nerves don't conduct properly, and then the brain tries to reinterpret the input coming into it and tries to make sense of what's happening, except it can't. The demyelination can also affect sort of other nerves which have a more motor or movement function. And if it affects the sort of what we call the root entry zones, sort of where the nerves are kind of being formed, it can sometimes cause a nasty face pain condition called trigeminal neuralgia, or a related condition which sort of more affects the sort of throat, really, the inside of the mouth, called glossopharyngeal neuralgia. Or sometimes actually you can get pain down individual nerves, or creating symptoms a bit like sciatica, but it actually relates to demyelination in the spinal cord. And where all of this is happening, and where nerves aren't conducting and interacting with muscles quite properly, people can sometimes end up with either spasticity and pain relating to that, or if they become quite immobile or losing the function of an arm or a leg, they can develop secondary musculoskeletal pains. And then sometimes MS on its own, or just some of the treatments we give, can cause people to have headaches. So you can get quite a wide range of conditions, some of which relate directly to the impact of MS on the nervous system, and some of which are sort of a secondary effect of the nervous system not quite working properly in all areas in some people.
Wonderful. And I think what I see in my clinics and what the literature supports, that 65% of people living with MS are affected in one or another way, that they present with acute or subacute pain or pain syndrome. How do you think that it affects the life living with MS and experiencing this pain? What is your sort of a day-to-day clinical experience when people come with MS and they start talking about the pain? How does that affect people in practice?
I think living with pain and living with suffering is really difficult for people. And people with MS are often quite used to symptoms, but pain is sometimes one of the symptoms they find the most difficult to live with. And it can cause itself quite significant emotional effects on people. And some people actually really struggle, and it really impacts quite significantly on their mental health as well. Now, this is a group of people who are having to go through quite a significant adjustment anyway to living with a disease like multiple sclerosis, which is a neurological disease. It can be progressive, or even if it's not progressive, you have to have some quite, profound treatments, some biologic treatments for it, which could cause other side effects and problems. And I think people can worry a lot about what their future is, how things are going to be, what their mobility is going to be. But being in pain, it can particularly impact on people's sleep. It can just make it difficult to do day-to-day activities on top of any incapacity that you already have from the MS. And it can really, as I say, it can really quite profoundly grind into people's mental state. It's very hard living with suffering. And none of us are kind of really born with the skills to deal with it. We all deal with it in different ways. But pain is a real silent phenomenon for other people. Somebody once said to me, look, Dr. Natusch, if I turned orange when I was in pain and people could see how orange I was, life would be so much easier because people could just look at me and see. But I'm just left with the option of either grumbling about it or bottling it up, neither of which are particularly great ways of dealing with it. So certainly when we look at pain in people, we would look at not only just the biological reasons people have pain, which is what I kind of outlined, but it's the impact on their physical and emotional functioning, which we think is extremely important, and which we do try and deploy different ways and different techniques, often psychologically informed, with the therapists that we're working with, who are working alongside as part of the team we're working with to help support people.
So how can medication be used to manage pain in multiple sclerosis patients? What are the benefits and what are the side effects using the medicine in managing MS pain?
Okay, well, it kind of depends on the mechanism that's causing the pain in the first place. So if we go back to what I said a bit earlier when I was talking about a little bit about the biology of pain in multiple sclerosis, a lot of people have nerve pain from nerve dysfunction. And then sometimes people have some musculoskeletal pains relating to immobility or other problems, and then sometimes people have spasticity. But if we go back to nerve pain, then very fortunately there are some treatments for nerve pain that people can often tolerate reasonably well. It doesn't always help everybody all the time, though. But the most common drugs that are recommended for nerve pain by the National Institute for Clinical Health and Excellence, or NICE as we sometimes call it, are drugs from the antidepressant and anti-epilepsy class drugs. Now, basically, people often worry when we suggest they take antidepressants that we think that they're kind of making it all up, it's all in their head. But in fact, there's very strong evidence to show only certain types of antidepressant drugs work. So the very classic sort of drugs that are often used, like fluoxetine or Prozac, which are serotonin reuptake drugs, don't actually help at all. It has to be drugs that impact on the reuptake of serotonin and noradrenaline. And in fact, one of the best class of drugs is a very old-fashioned type of drug, which has been around for a very long time, a class of drugs called tricyclic antidepressants, where we use drugs like amitriptyline, nortriptyline, which is just an amitriptyline metabolite. It's a kind of cleaner form, or imipramine, or sometimes lofepramine, are all drugs from this class, and they can be very helpful, but the dose that works for pain or nerve pain is much lower than the depression dose. There are other more modern drugs, particularly duloxetine is quite well researched, mainly in diabetic nerve pain, actually, not MS really, to be honest, but it can be very useful. And these drugs work by boosting inhibitory systems. Now, the brain does have systems for reducing or switching off pain, and actually the antidepressants work through these systems, which are actually systems in the brain using serotonin and noradrenaline. So in some respects, this class of drugs is one I really quite like, and patients often tolerate well. The only problem with antidepressants really relates to the more modern antidepressants. There are side effects from all of them, really. One of the biggest ones being weight gain, which people really don't appreciate at all. The more old-fashioned antidepressants can cause things like amitriptyline, can cause things like sometimes a dry mouth, or they can be a bit sedating. And that's fine, in fact, if they help people sleep at night. People sometimes are quite appreciative of that, or they can constipate people a bit. But the low-dose tricyclic antidepressants we use don't particularly cause withdrawal symptoms. But the drugs like duloxetine can cause antidepressant withdrawal symptoms if they're abruptly stopped. And those can quite often mimic some of the symptoms people have in multiple sclerosis, and you get these funny electric shocks all over your body. And in fact, people think that they're missing the drug, that if you like, they think they're having a flare-up of their MS, well, they're not. They're actually having antidepressant withdrawal because they've abruptly stopped their antidepressants. This doesn't really happen if you come down on them slowly or taper them, as we say. So as long as you don't abruptly stop drugs for pain, you come off them gently. And if you do that, that ameliorates that effect. The anti-epilepsy drugs have different mechanisms of action, which I won't go into because it's not really relevant in this kind of public broadcast, but they tend to work on different receptor systems, basically. They have a more generalized effect on the central nervous system. And although they can be extremely good, the major problems that I see with people are weight gain. In women, thinning hair and hair loss can be an extreme, and I've never met any person who thinks gaining weight and losing their hair or getting thin hair is a particularly great thing. And then people particularly see that in women having anti-epileptic drugs for migraine, actually. Or there are drugs called gabapentinoids where that's slightly less of a problem. But with all of these drugs, they're not particularly safe in pregnancy. They can cause fetal abnormalities. And memory problems can be quite a big issue with this class of drugs, in my experience. People get quite forgetful. And in a condition like multiple sclerosis, where you can have central nervous system effects anyway, people don't always find that helpful, and they don't always realize it's the drug. So there are drugs, they can actually be quite good for nerve pain, but they come with side effects and complications. You've got to really think about them quite carefully and have a good chat to your doctor. And if you start getting effects you don't really recognize, or you wonder about, so some of these things I've maybe brought up, is always good to sort of get some medical advice or some specialist pharmacist advice about that as well. There's a major class of drugs which we really try and avoid using altogether are morphine-type drugs. We do use certain types of morphine drugs occasionally, but we don't use them very often. And the reason is, unfortunately, and this is well seen in the addiction literature, morphine drugs actually sensitize pain systems over time. So it's very clearly known in the headache literature, for example, that one of the worst things you can do for headaches is give people morphine drugs. It often makes it worse. And many people have heard of painkiller-fueled headache. Well, we also know that actually they can cause a general increased sensitivity for pain. And we often think actually they can actually cause more problems than benefit in people. So we do occasionally use certain types of morphine, but they're not pure morphine drugs. They're drugs that work on other systems. So occasionally we use drugs like tapentadol, which works on serotonin and noradrenaline, a bit like the antidepressants, or drugs which are morphine drugs, but they work through other systems as well. But again, you've got to be terribly careful with any painkiller. As I've often said to people with a headache, the problem is any drug that can cure a headache can in some circumstances cause a headache. And these effects aren't seen in the short term, but they can become more apparent if you've been on them longer term. Plus, unfortunately, morphine-type drugs people become tolerant to, so they kind of stop working, really, which is over time, which becomes a problem.
And there's also interaction, perhaps, with if a majority of people that come to see us, they are on polypharmacy, they are on gabapentin, pregabalin, amitriptyline, duloxetine, and opioids somewhere in there. It's slightly worrying because they all have side effects in a way, and so optimizing that care plans, should it come from the healthcare providers, professionals, and what the role of us playing in this pain management, where is this common ground as a pain consultant and neurologist? I feel as neurologists, we exhaust our resources, which we usually use amitriptyline, pregabalin, gabapentin, duloxetine, and if we fail with that therapy, we quite often refer to the pain services. So what is your view of this approach? And
I think pain is everybody's problem, and I think everybody who prescribes for patients needs to be singing from a common hymn sheet, really. And often, in South and West Devon, we use the South and West Devon formulary, which is a very good and more locally specific guide to medication. As secondary care consultants, we really set the tone for prescribing. So every letter we write to patients, to pharmacists, to GPs, to other doctors, is educational in a way about medication. But I think really we're dealing with very powerful psychotropic drugs that have a very profound influence on the mind and the central nervous system. And I think we've just got to be very respectful of them. And really, my adage is always people need the minimum dose of the least possible drugs to achieve the effect, if we're using drugs at all. But in pain, drugs also are a choice. And sometimes people find the side effects of drugs are actually more problematical than the benefits. And actually, in some circumstances, people sometimes, particularly if they've learned other ways of managing pain, actually choose to become less reliant on drugs. And we don't push drugs onto anybody, really. We don't go out there saying, you must take this, you must take that. All medication is a choice, and very, very few medications are for life, in my experience. Things like MS, nerve pain can change over time. And what's really important is that prescribing needs to change to marry up with that. But yes, we don't suggest multiple drug prescribing for one thing, and we often do simple things like, say, use one drug at a time to see what effect it has, increase it slowly, decrease it slowly, to what we call titrating in and tapering out, to really try and find out what's the level that is most effective with the fewest side effects. And then we have to sit down and have a conversation with people about what are the long-term effects of taking this drug. And there are, as we've outlined.
When I was a medical student, I remember there was a lecture around pain types of the pain and syndromes. And one sentence that stuck in my mind was that pain is experienced as 50% physical, 50% is psychological.
Well, that's interesting you say that, Agni, because certainly the international definition of pain from the International Association for the Study of Pain is as a sensory and an emotional experience. And in fact, if you look at brain scans, functional brain scans, which look where the bits of the brain light up when people are hurting, actually it's quite slow. There isn't a pain cortex in the brain, like there's a visual cortex, or there isn't a speech area, or there's a speech area. Specific bits of the brain do specific things, and I won't tell a neurologist about this because it's a bit of a grandmother and egg conversation, But with pain, in fact, actually multiple parts of the brain are processing pain quite slowly, slow enough that it can be picked up on functional scanning, which takes a few seconds to actually detect blood flow changes in the brain before people perceive it. And the one thing we really know about pain is the brain really compares its input to what it already knows and understands. So how you perceive and how your brain reacts to internal stimulus and pain is very different with different people. And there is almost no linear relationship between injury and how much people actually hurt, because the brain itself also has very powerful inhibitory systems for pain. Sadly, these aren't under conscious control, because if it was, it'd be great. You could just switch off that painful leg for an hour or two while you got on and did other things, but you can't. But what we do know is in some circumstances, like battlefield injury, people don't feel pain at all. And that's an example. And the placebo effect as well. Basically, these are reflections of the brain's ability to modulate its own input. But what we know is that unfortunately emotional distress inhibits the pain inhibitory systems. So the brain has inhibitory systems for pain, not under conscious control, but if you're very distressed or stressed, its ability to do that's impaired. So a lot of people with pain will often tell me, and they often find themselves, that if they're very stressed or upset, their pain is worse. And that doesn't mean the pain's in their head. It's about the way the brain processes and perceives things. But it's one of the reasons why we would advocate using psychological techniques, and in some circumstances actually having psychological therapy alongside medication. We don't ever really, certainly in pain clinics, recommend painkillers on their own. They would always come packaged up with a wider aspect of care for people. And there are a lot of resources out there to do that. Now, obviously, if you've just had a simple injury, you've injured your ankle, you might need to be on anti-inflammatory drugs for 5 or 10 days and then stop. But the circumstance with MS that we're talking about is a much more complicated picture than a simple injury picture.
Yeah, and I also noticed that people who have poor sleep quality, they also quite often refer that the pain gets worse if they haven't slept properly. So it has got a crucial role in management of MS. So we quite often these days ask about the quality of sleep. And if it is the pain that keeps them awake, of course, we would tackle that issue. But what are the non-pharmacological approaches to managing pain in people with MS?
I think we would generally sort of apply the approaches we'd use to anybody with persistent pain, and we wouldn't particularly distinguish between MS or not, really. I think it's always important just to think of really simple things. Okay, sometimes, so if you have a simple painful area, then something like a hot cold pack can be lovely. And you can get things like wheat and lavender packs that you can microwave, put around your neck for sort of some musculoskeletal pains. It's very simple non-drug treatments. And we mustn't ever forget these really straightforward things, which actually help a lot of people. When we talk about, people often talk about self-managing pain. What that really is there's a series of skills people living with long-term conditions like pain actually find quite helpful. And it's picking up some of those skills and trying to apply them in daily life. Now, some of those skills are skills around activity management, working out what do you do before it starts to hurt, modulating your activity, taking different approaches to activity. That's something using techniques called pacing and other things, which are often taught through occupational therapy. Physiotherapists also do a really good job because very generally with the body, keeping moving is good. And we do try and encourage people to keep moving. And we do try to stop people avoiding movement, particularly of painful limbs, because we know actually that one of the worst things we can do for the body is to stop using it. I know in MS it's really hard, and people might be saying, but that's not relevant to me because I can't move my legs anymore, thanks very much. But the bits that people can move, muscles really benefit from movement, and you can get all sorts of secondary pain when you can't do that. Now, I know in MS, some people, because of the underlying condition, can't. But physiotherapy techniques can be extremely useful. And what's quite surprising really is that in a slightly different area, in a condition called fibromyalgia, which is a widespread pain, sometimes people with MS have it, sometimes they don't. But people who just have fibromyalgia on its own, they compared graded exercise to Tai Chi. Now, Tai Chi is a type of what we call mindful movement. It's been around probably since, I suspect, almost pre-recorded history. Somebody might take me down on that one, but it's been around for a very long time. And actually, people reactivated and were able to move better with Tai Chi, and actually it was a very good way of helping people who really hurt get moving. So our own rehabilitation team tend to use psychologically based movement techniques, the best ones of which I think actually myself, in my own opinion, are yoga and Tai Chi, which are, yoga's the Indian version, Tai Chi's the Chinese version. The Alexander techniques are kind of a Western version when you look at it a little bit, but I think the others are much more developed. And we find that simple movements that link posture movement and breathing alongside some psychological techniques based on mindfulness actually can be very helpful for people sometimes. not all of the time. But what we do know is that if we can teach and help people with their general well-being, apply principles that we know about well-being to health, and then put that alongside a fairly individually tailorized package for people, because it has to be very individualized. That's why it's very difficult to sort of generally describe. It can make a big difference for them. And I know that the MS patients struggle a lot. I know, and I look after people who are entirely wheelchair bound, who can't move their arms or their legs. So, I'm not saying, sort of do Tai Chi. It sounds a crazy thing to say somebody in a wheelchair, but what I can say is that we do have, and on our own trust website called Reconnect to Life, we do actually have some links, including things like Tai Chi and yoga that can be done in a chair. So you can do some of these things sitting. You don't always have to be standing and moving to do them.
Absolutely. I think movement is essential part of living with any chronic condition, and also lifestyle implications like diet. We speak a lot with people with MS these days during these interviews and outside this podcast and in the clinics. Actually, people do notice that if they eat processed junk food, really they feel more symptoms living, including pain, to be honest. Have you noticed in your practice that the lifestyle, diet, we discovered the exercises, they play a positive role in overall outcomes. But what about diet? Have you noticed any improvement?
I must confess, I don't usually specifically talk about diet myself very much. Being a pain medicine anaesthetist, it's not my own area of speciality. I do know that I have colleagues around the country. For example, my colleague Deepak Ravendram in his book, The Pain-Free Mindset, people sometimes talk about anti-inflammatory diets. I don't know enough about that subject really to sort of comment really. I think what I would say is that a group called the Mental Health Foundation, on behalf of the government some years ago, tried to produce a 5 a day for mental health to complement your 5 a day for diet. And I think there is good advice really about diet and health actually just on the NHS websites generally. And we do know that actually sort of your 5 a day does actually help you. The 5 a day mental health ones are really interesting because they're very powerful and they're very evidence-based and they're very simple. And those 5 things are, the first one is connection with other people. The number of social connections you have, the more widespread your friendship network is, the more likely you are to be able to deal with difficult things in the future. Be active. Be as physically active as you can within the circumstances as you are. Take notice. We live in this amazing, beautiful world out there, connection with nature, sort of what I would call them as all like being plugged into the planet and the universe, are really useful things. Take notice, be mindful of the world around you. Keep learning. Learning new skills and learning new things is actually very good for you. And actually giving back and volunteering, interestingly, is very good for your mental health as well. So I think, certainly when I do talk to patients, occasionally with diet, I do refer people back to dietitians sometimes. I think there is some evidence coming along now about diet and health, but I can't really comment on that myself. But what I do comment on a lot is about the 5 ways to well-being.
Yeah, so talking about the MS-specific diet, so there are some emerging evidence of Mediterranean diet, ketogenic diet and intermittent fasting that plays the role in improving the patient's outcomes living with multiple sclerosis. So it's really important to think about that your body is like a unity, and it's like an instrument that you need to nourish various different aspects, and the pain is a chemical shift in the end of the day, and you want to supply some really nutritious products that actually will booster the element of how the brain works and what the elements and the chemicals are being shifted and to help the neurons to communicate with each other. So it's really important. And then create an environment that the drugs could work better. If your diet is appropriate, if your weight is adequate, you're really going to benefit from the medicine that you take to support and help to alleviate the pain. So, and if you're a person who lives with multiple sclerosis person, again, it's important to educate yourself and understand MS and its pain, what it's like living with it. Open discussions in a family is really encouraging. We're encouraging everyone to talk about the pain and instead of asking people with MS, how are you? You would probably be in the better position if you say some specific questions like, how's your pain today? Did you sleep well last night? So really addressing that issue, because then people with MS will feel that they are being looked after. And of course, a lot of help is required for people with MS. And if you can assist with the routine tasks that are usually challenging for some people, so that's something that a lot of people would appreciate. Also promoting relaxation, gentle massages, warm baths, and playing some calm music and sort of it can ease the pain and stress at the same time. So relaxation therapies and techniques are super important, and being very patient, joining maybe support groups and an advocate, being as an advocate for the people with MS needs, and ensuring that there is accessibility at the venues that you attend, joining an MS walk or fundraising. So simply as that is celebrating small wins. Living with the pain is sometimes overshadow small joys, and celebrating the moments of relief, the achievements, the milestones, no matter how small they are, is super important. So I would like to summarize, and you took a lot of information today, and the key message is here that pain is debilitating. It affects the quality of life, but there are ways with a medicine and non-pharmacological approaches to manage the pain in a very efficient way. Usually combined holistic approaches is the way forward. And thank you for listening to today's episode of Be Well with MS. We hope you found this discussion with Dr. Douglas Natusch informative and helpful in understanding the relationship between MS and pain, as well as different approaches to managing it. As we learned, pain is a complex and multifaceted symptom that requires a comprehensive approach that addresses both the physical and psychological aspects of pain. It is also important for MS patients to work closely with their healthcare professionals and advocate their needs when it comes to pain management. We encourage you to continue learning about MS and its various symptoms and treatments, and seek support and resources when needed. Thank you again for tuning in, and we'll see you next time. Be well with MS. Thank you, Douglas, for attending today.
Thank you, Agni.